Is the story I'm going to tell you in the next 20 minutes or so. It's a little bit to do with hemorrhage. It's a lot to do with percutaneous or minimally invasive or endovascular techniques. And at the end of it, I'm going to tell you a story of how the hybrid OR at least came into Calgary, which we've since sort of published that process. So hopefully, for those of you that don't have them, that are considering them, that will have them, you can learn from our mistakes. So this is our trauma center. Actually, it's our hospital, Foothills Medical Center. And it's about 1,200 beds. It's a big facility. It's 12 buildings. You can come up and see the hybrid suite or see us at any time. We're pretty happy, fun Canadians. So come up and visit. We'll take you skiing if it's in the winter. The hybrid suite, let's go backwards there, lives in the big white building in the middle. It's on the third floor there, sort of deep within that building. This is my house right here. So just knock on the door. I'm not far away. This is the only motherhood slide I have, and clearly if we're talking about hybrid suites, really what we're talking about is bleeding, and specifically bleeding to death. There's no question we know that most preventable causes of death from trauma within the early hospital setting are due to exsanguination, probably about 80%. Our job as traumatologists, trauma surgeons, emergency room physicians, whoever that is diagnose bleeding, to treat bleeding, and concurrently resuscitate those patients. This is an important paper, I think, and I put it up here for reference. It's getting a little bit old now. I guess it's 2007. It's a Canadian paper from Sunnybrook, where Dr. Nathans runs the ship. And what it shows us is that the major cause of bleeding, potentially preventable bleeding, and as a result trauma death, comes in the pelvis, in the form of pelvic bleeding. And I think as traumatologists, again, however you describe that terminology, these are the patients that really do challenge us the most on too many occasions, particularly in blunt trauma centers like we exist in Canada. I will just throw this up as a disclaimer because I don't want to go too far down this road of fun hybrid suites and technology and lose the obvious, meaning that most patients with vascular injuries need the operating room, as Dr. Macrisy said, lickety-split, and they need to be treated with traditional modalities. We always have to keep that in mind, and we have to apply technology to the appropriate patients as we go along. So what is trauma interventional radiology? It's just one descriptor. Well, it's a minimally invasive or really endovascular technique to stop bleeding. And for a simple guy like me, an HPB and trauma surgeon, I really break it down into two things. We're trying to block bleeding blood vessels, and we can do that with either embolization material, gel foam darts, coils, whatever, or we put up balloons. And the most sexy recent example, and the remarketing example really is Roboa. Tomorrow, I'll talk a lot about balloons. Or we can realign blood vessels, right? Taking broken blood vessels and stenting them in some way. And I'm not really going to talk about that. That's a whole different discussion. Where do we use trauma IR or potentially a Raptor scenario? Well, it's bleeding from almost anything. It can be solid organ, the pelvis we talked about, and more abdominal vascular issues as well. We'll get into that. Now, as I sort of alluded to, this isn't really totally new stuff. The concept of putting balloons in aortas has been around for a long time. And I put this paper up here by Martinelli just because I sort of like it. It's a very low-tech way of Roboa, something that I was trained to do 6 or 7 years ago. You don't need super high-end technology, but what we're going to see with Dr. Rasmussen and Scalia and really the whole trauma world going down, for example, the Roboa pathway, is that technology, the demand for that technology is going to be improved substantially. So the access catheters are getting smaller, is probably the dominant issue. Again, as a traumatologist, I think we always have to ask ourselves, what's our role? We really can break it down into emergent and urgent, minimally invasive techniques. And I think on the trauma side of things, really, we're talking about maybe embolization, but more commonly balloon occlusion. We should leave stents and stent grafts, which are fundamentally different, to people who are doing that every day, day in and day out. This is an important paper by John Pryor, and as you can see now it's almost 10 years old. But what John did was very simple. He looked at two different specific time intervals and looked at their interventional radiology related to trauma, sort of workflow or footprint. And the take-home messages from this paper are multiple. The first is that during that transition time around the year 2000, they were clearly moving from less diagnostic interventional radiology techniques or purpose to more therapeutic purposes, particularly with regard to pelvic and hepatic injuries. They were also transferring more hemodynamically unstable patients to the interventional radiology suite. Now, we can talk for hours, I think, and debate that. The reality is it's happening. It's happening in high-volume centers, and it's becoming more common. And that really drove then the rationale for creating a one-stop shop like a hybrid operating room. We also use it obviously in the context of damage control surgery and damage control resuscitation. Sometimes we use it before we go to the operating room. Sometimes we use it after. Sometimes we use it before and after. It's a powerful tool. The real question, though, is at 2 in the morning when we're sitting in the trauma bay or the emergency department or the shock suite, whatever it is that you call it at your institution, and we're trying to decide where's the bleeding? Where do we need to go next? Do we go to the operating suite or do we go to the interventional radiology suite? And that decision, if you make it incorrectly, can clearly be deadly. This also comes from Dr. Pryor's paper. And the answer to that question, I think, really revolves around the concept of what resources you have or don't have at your institution. So what's safest for that patient? Where do you need to be? Who's around to help you? And so on. This is the footprint of not the big white building I showed you in Calgary, but the actual where the emerge is in a separate but connected building. And you look at that, and the skull and crossbones there is where their interventional radiology suite was, and the happy sign is where the operating room currently is and was. And that doesn't look like it's very far away, and in fact it's not. But our mortalities for similar injuries were very, very different there. And there's lots of reasons for that. There's delays, there's temperature, there's resuscitation abilities, and so on. So again, it comes back to knowing your institution. Again, a lot of this has been around. This is a paper I like very much. It's from 2010. It's a Japanese paper. And they make the argument that you can do this in a mobile way. And we know that from vascular surgery. Without any question, they would bring a C-arm into their emergency suite and use that on occasion as well. So you can get around spending millions and millions of dollars on a hybrid suite. But if you're really lucky, you have a hybrid suite, or maybe you can obtain one. In Calgary, we call this a Raptor, and I'll explain that in a second. You can see it's a big room, there's no doubt, and it's certainly walking towards utopia, but I don't think really quite achieves it. We've been lucky to publish a fair bit on the concept of a Raptor, which we coined as resuscitation with angiography, percutaneous techniques, and operative repair. In other words, it's a fancy way of saying hybrid suite. And I certainly don't want to make Calgary sound like it was the original. The original exists in the United Kingdom. It's been there for a long time. The second high-volume center, or at least moderate-volume center to use it, was, and still is, in Liverpool Hospital in Sydney. And Calgary, I think, probably was sort of the third major center to adopt it. The reality, though, is I really like this comment from Tom Scalia that's now getting a little bit dated, but he was talking in the context of pelvic fractures, and he said in an ideal world, these patients would be cared for in an operating room with biplanar angiographic capability, giving the clinician the ability to deal with multiple problems simultaneously. And I think if you're ever going to sit down and read or think about the hybrid suite in a summary sentence, that's probably it. So what's our role, again, as traumatologists? The second time this question has come up. Well, the reality is that 70% of emergency on-call angiography occurs in the out-of-hours time frame. So the radiologist is at home. The interventional radiology team is at home. So they're on call, but they're not in the hospital. Less than 15% of pelvic angiography is performed within 90 minutes. It's been shown in multiple studies now retrospectively. And the important thing really is it's like all these critically ill patients. You need a quarterback. You need somebody who understands the multidimensional and continually progressing or changing nature of these patients. So you have to go with that patient wherever they are. This is a really important paper, I think, and it clearly shows that every hour, which is a long time interval, with regard to delay to angiography, represents a 47% increase in mortality. When we looked at this paper critically, we said, well, there's no way at the Foothills Hospital in Calgary where we have all these resources and supposed to have all this oil and gas money that we're having these problems. Well, sure enough, when we did look at it and we did eventually publish it, we were doing no better. It was a major issue. And so that was part of our sales job, at least, or our drive to try and obtain a hybrid suite. The other thing that we were really lucky of in terms of timing in Calgary was the building of the construction of that large white building. So that didn't exist. We were able, as you'll see in a second here, to rough in this hybrid suite as we went. So if you look at the process of bringing one of these to your institution, we broke it down in our manuscript into 5 or 6 different categories. The first is conceptualizing it. So creating utopia. In a perfect world, what would I put into it? Then there's reality, or the practicalities of trying to do that. There's picking technology, what vendor are you going to use, what combination of hardware are you going to have. The room layout physically and the design of that in terms of workflow and manpower in that room. And then human factors as well, which is something that my partners and I had really honestly no idea about, but that we seem to learn a fair bit under the guidance of our administrators. And then finally, oversight and going back to this and refitting it. So I'm going to go through just basically in a picture format each one of these. So if you sit down and you think to yourself, I want to create the perfect environment, you're going to be able to do a lot of things. It's going to be an all-purpose scenario. You can do any kind of imaging you want, you can do any kind of operation you want, and you can do any sort of percutaneous technique that you would want. And in theory, you can put all these in one room. There's no question. It's going to be very expensive, and it's going to be in terms of geography, difficult. At the end of the day, you end up starting to sacrifice elements of that utopic view. So it's important, again, to really look at your patient population and really understand what it is that you need most. The practicality of it is that it can be very expensive. The suite in Calgary was just over $5 million to build. Donations were private primarily. It was about $3 to $3.5 million, and the government kicked in another $2 million with regard to capital funds. All the way through this process, though, you have to be prepared to answer to administrators and politicians and nurse managers and your chiefs and chairs as to why exactly do you want this. So again, it goes back to thinking about it up front and really having that answer clear. So in Calgary, there's something called the Calgary Health Trust. It's a fundraising organization. We all have them. As usual, we engage them. We had trouble initially raising funds, there's no doubt, until we put a patient face to it. And this gentleman, Joseph, on the left, was a gent that had a really bad pelvic fracture, went to the angiography suite first, then to the operating room. Survived, is a well-spoken guy, and as usual, like I said, if you put a public face on it, it tends to move the money along. The other thing that you really have to consider when you're doing this is who's going to be involved in it. So getting all the stakeholders and all the folks who are either clinicians or administrators who are going to be engaged in a room at the same time, talking about things. So at the end of the day, someone needs the vision, someone needs the goal to get this done. And I lead a lot of that credit to one of my partners, Andy Kirkpatrick, who spent a couple of years trying to do this. What about the technology? Well, that's the funny part. A bunch of trauma surgeons trying to talk about technology with regard to interventional radiology is sort of a joke, quite honestly. So you need to really deeply engage your interventional radiology colleagues because they have a much better sense of that. We put in a Philips, that's just one brand. Liverpool Hospital in Sydney uses a different one. UK, and I'm sure lots of people in this room use different technologies as well. They all have their pros, they all have their cons. You clearly need in addition to the hardware, you need the software, and you need the details. So the interventional radiology team, again, extremely important. What about the room layout and design? So this is the footprint of what we ended up with in Calgary. For us, it's 2 regular-sized ORs, so it's 155 square meters. Down here on the right, this is the angio control room. This is a big sort of storage open facility. This is where the gantry to the angio arm, as well as the CT scanner, sits. And I'll show you some pictures in that in a second. So in the initial mock-ups, and again, down here on the right, you can see the building was physically being built, so we could really move walls, which was kind of neat. We thought, well, we needed it to be sort of 3 ORs, and it was clearly too big. It was felt like sitting in a hockey rink or a football field. It was just quite odd. So we started to design smaller rooms and creating mock-ups. These are just plywood painted, basically angio C-arms and tables. It really starts to give you that sense. And then we went too small, so we had to expand it back out again. The other thing that was really important was the human factor analysis. And as I mentioned, we really knew nothing about this. These are camera views, and we would run triage scenarios. We also ran a number of different injury scenarios, complex injury scenarios, to see exactly how the flow was in that room, where things were, what was the challenge, and so on. This is a human factor analysis flow diagram, and so the yellow dots are where the people are standing. You can see there's far too many standpoints, but you can see that red sort of means there was too much motion there. So at the end of the day, for example, based on this figure, you'd say, well, there's a flow problem in here. There's too many people in too tight a place, so you have to create space or move this over, do something in some way. So these pinch points or bump locations are key. At the end of the day, you have to debrief all this clearly. You have to be sure all the stakeholders they feel engaged, that the culture is good, that everyone believes in the project. For anybody that wants to look at those details, this was the paper that my colleague Andy Kirkpatrick, as I mentioned, published. It's an injury. It's just out. At the very end of the day, though, oversight and looking backwards and continually refining these procedures is key. It means a lot of meetings, to be honest. It means a lot of critical review of individual patient cases. You also need clearly an important and revisitable trigger criteria with which to use the Raptor. One of the biggest fears of administrators is always the over-triage of patients to the new toy. It's expensive, takes twice the number of staff, so you have to be vigilant about that and try and prevent that from happening. At the end of the day, the trigger criteria for us are really summed up in the top box, which is that it's confirmed or highly suspicious intracavitary sources of shock. They would go to the Raptor suite. I think I'll stop there. Thank you.